Hello, everyone. Welcome to EULAR 2025. This is the day 3 recap. I'm Jack Cush with Room Now, and I'm joined by 3 friends and 3 of the faculty who have been dutifully covering this meeting. They've been everywhere, tweeting, writing, and now doing a video. Today's session, the recap, we will discuss our favorite abstracts of today, day 3, here in Barcelona. As I said, I'm Jack Cushwood Room. Now I'll ask my panelists to introduce themselves. Aurelie,
Hi, Aurelie Najm from Glasgow.
Janet,
Janet Pope, London, Canada.
and Yus.
Hello, Yusof from Leeds, United Kingdom.
Yes, and we're all here back in our rooms on Zoom recording this for you. We're going to each present 2 of our favorite presentations and abstracts from today. Let's begin with Yus.
Okay, so my one of the favorite abstract today is pertaining to the use of certolizumab in pregnant women with antiphospholipid syndrome. So the title is OP0273. So the rationale behind this was from the animal studies that showed TNF cause placenta dysfunction. And they did some work in animal model that if you give TNF inhibitor, it improved the outcomes. So this is a study in human, which is a single arm, open label study. So the population was women with APS and also with lupus anticoagulant positive. So when they did the trial, they needed 45 participants, and if 20 and if there was only 20% adverse pregnancy outcomes, then the trial could be considered positive, and potentially you can base that to power in a phase 3 trial. So the adverse pregnancy outcomes that they defined included fetal death during more than 10 weeks gestation, or if you have severe preeclampsia, and also if placenta problems and causing delivery less than 34 weeks. So what they found in the study, so they administered the certolizumab between weeks 8 to 28, and they found for the intention to treat an population, there were actually exactly 20% adverse pregnancy outcomes, and per protocol, it was 18%. So these studies showing like proof of concept that administering in TNF inhibitors such as certolizumab during the pregnancy actually improve the adverse pregnancy outcome. And you know that these pregnant women are high risk. And just to let you know as well, apart from the certolizumab, they also administered your usual standard of care, which is the lower molecular weight heparin and also low dose aspirin. Yeah.
So Yus, how do we know that this was a significant result? There was no control population.
Yeah, so basically the control was based on the previous studies. If only standard of care, which is like lower molecular heparin and also LDA, like just aspirin, so the rate was 40%. So basically they powered it. If you improve, by 20%, then that will be a positive outcome. Yeah.
So this was published last month in ARD and is available to everyone. It's called the Impact Study. I think this is great. Any other comments?
So I have just a brief one. I think the standard of care has really changed. I don't think it'll be that anyone will be willing to sign up for a trial. This study, albeit some of it was run during COVID, but it took about 10 years at multiple sites to enroll. And it's a very, very important study. But even without a control group, my next patient who's triple positive APS with probably an outcome in past, a miscarriage, a DVT, a stroke or something, I would give standard of care and I would offer this because we're not using certolizumab pegol indefinitely. And we already know the safety in pregnancy and RA. So I would find it very difficult to do a trial now, even though obviously we'd love the gold standard.
Yeah. I think one of the big surprises here for me was kind of gets away from the old idea that recurrent fetal loss could be treated with steroids and an inflammation targeting drugs, and we kind of went away from that in this population, going more towards anticoagulant-based therapy. But this says there is a role, maybe. So we'll see. All right, let's do our next one's going to be Aurelie.
Yeah. So today I was quite interested with the treat earlier 5-year extension data of the trial. So it was oral presentation 0324. So treat earlier was a randomized control trial that was presented before subclinical RA, ACPA positive and ACPA negative, so two groups, and they did methotrexate for 1 year after an IM injection of glucocorticoids, and they had the placebo control. And so what they showed back then was that methotrexate wasn't extremely great. The primary outcome was whether or not they could prevent RA and retard it, the clinical RA. And so, yeah, I wasn't really convinced by it back then, but when they looked into different populations, it seemed that the ACPA negative population would benefit more as opposed to the ACPA negative. And so what they confirmed in this 5 years data set was that indeed those ACPA negative patients, they do seem to benefit even after 5 years from the methotrexate, which I found really interesting, in particular, if you put into context with the data that were presented by Endicott on the first day in the plenary, the 3 years extension of Alto, which was the Apipra one, which was abatacept 6 months. And those who seemed to benefit was those very ACPA positive, multiple IgG rheumatoid factor. So it's almost in my head now. There is this group of patients, very seropositive, very high risk, and it's almost methotrexate is not enough to prevent RA for them. Maybe they need some different mechanism of action. While those seronegative patients, maybe methotrexate is enough for them to prevent. So that's kind of how I see it. But I did not see the debate today. I didn't have the chance to do that. I don't know if any of you guys did, but I'd be interested to see what was said as well. But yeah,
Yeah,
that's kind of how it pans out for me after this.
yeah, there was a debate today. I missed it too. I was in another session about whether
Mm.
you should or should not treat clinically suspect arthralgia with the aggressive therapies. And they were going to use this data, like the treat earlier and the Apipra and the ARIA data, to defend themselves or to argue against it. So, Janet, what do you think of this data?
Right. So first of all, I think it's kind of neat, the concept of prevention before your immune system has epitope spreading, say if you're ACPA positive. The effect size is pretty small, but the fact that the graphs still diverge on the, as of for instance, on the abatacept data, they only got 6 months of abatacept and there's still a change. So if it was my identical twin, if I had RA and the identical twin was ACPA positive or vice versa, I'd kind of say, why don't you do 6 months of this and you won't get a chronic disease? But I think time will tell. And I think we'd be all over it even more if it was a drug that we could easily get access to. The final thing is, I'm not sure how many of these people ever will get RA, because it looks like if you enrich for a population by 5 years, up to 60 or 70% will have RA. So it's pretty enriched.
Absolutely. Yus, what do you think?
Yeah, so I missed this abstract as well. Can you just check was there any changes in ultrasound or like erosion or anything
So the
Aurelie?
treat earlier, the primary was either having clinical RA or there was a combo of physical function. I would have to check again for imaging outcome, but I don't think I saw any of it because they were already had subclinical inflammation on imaging. That was as an entry criteria.
Mhm.
Yeah, that was one thing that was unique. That was an entry criteria. They didn't have to have, unlike the other prevention trials, you had to be seropositive to get in. This one you didn't. You had to have
Yeah.
arthralgia and subclinical arthritis or inflammation, mostly tenosynovitis. One of the big questions that came up was, well, if they're seronegative, are those seronegatives really seronegative? And turns out a minority of them do have rheumatoid factor, so they all
Mm.
are seronegative for ACPA.
Yeah.
And ACPA seems to have a better influence in predicting future development of inflammatory arthritis. But other autoantibodies like carbamylated P and and the other ones were either not there or just in very low frequency. So,
Right.
yeah, I think this is going to maybe change the way people think about this.
And I
Okay.
do think Aria, sorry to interrupt there, or Pipia, the one, the abatacept one that they presented, those who did get RA, who were on had received previously abatacept, they actually said their disease was more mild and they had
Yes.
less erosions, but the erosions were just a very small amount. I think I remember that from the plenary.
Yeah.
Just add a quick question as well. That just also build up the question whether how long do you need to treat them, with methotrexate? I mean, is there any answer there, or more longer follow-up will be needed if they taper methotrexate?
Well, at 5 years, those who were treated with methotrexate for 1 year, the
1 year.
ACPA-negative ones, there was still lower percentage of them progressing to RA. So that's a 5 years effect of a 1 year intervention.
Right.
So in all these trials, it has been a partial treatment. The earliest one was Prairie, where they got one infusion of 1,000 milligrams of rituximab and had 30 months of benefit. The two abatacept trial, Apipra and Aria had 6 months of ABA, and Apipra had 1 year of ABA, but they both show 4 and 5 years effects. So, and the question is that really what's good about this study is that the lines don't come together. It looks like there's something different. All the other studies, their lines ultimately do come together, and I think it's good no matter what because you have this long disease-free interval, and who knows, as Janet's point was, maybe come back as RA, but it's kind of mild or whatever. Do you change the trajectory or the aggressiveness of disease by getting them at this sort of intercept point with one of our interventions? So we do need to, I think, well, we like the old best study. I think we're going to see almost yearly reports on these cohorts and what happened to them. I want to see that myself. So, all right, who did Janet? You're next.
Yep. So I'm going to talk about an old drug, but some perhaps novel insights. So the first one is poster 0987. And this was a large group of patients from Taiwan who were on hydroxychloroquine for rheumatic indications. So lupus was common, but also RA, MCTD, SSC, other CTDs. So that's in and of itself a little bit interesting because often people are talking about drug levels in lupus. So what they wanted to look at was the varying by dose, but with respect to the toxic or subtherapeutic or therapeutic drug levels by GFR. And so they had 4 different ways of looking at dosing, and they had 4 different GFRs. So it was GFR greater than 90, so normal, less than 90 but better than 60, less than 60 better than 30, and less than 30. So, pretty bad, low GFR in that last group. And at 400 milligrams per day, the numbers are small because you start subsetting, but just to know, every patient, low N, with the lowest GFR, had a toxic drug level. Everyone, 400 milligrams, even if they're a big person, like higher than, where you're dosing your 5 milligram per kilogram, all of them had a toxic level at the lowest GFR. And even 200 milligrams per day at that lowest GFR, 1 in 4 had a toxic range. Now, low numbers because we're subsetting all over the place in this study. But in general, so 6 milligram per kilogram per day, all the low GFR people were supratherapeutic. And even the next two levels of like 60 to 90 and even the 30 to 60, even in those levels, 1/3 had supratherapeutic levels. And that's even if you look at lower dosing, so if you went about 4 milligram per kilogram, none of them had toxic levels in general of normal renal function, none at all. So I think the take home is we have to really dose adjust for GFR. This isn't something new to us, but it's not always discussed. And we did a study way back when. So two trainees were in the study with me, both of whom, one's a rheumatologist, one's going into rheum. So shout out to them. But we published in ACR Open Rheumatology in 2023. We looked at Lupus itself, adjusting for everything, seemed to be a higher risk of having retinal toxicity, possibly because we really want them to be adherent. We talk about it more, possibly because of GFR. But I think we just have to be very careful that if their GFR is low, but not that low, maybe you try to get a drug level. So I think the take home is small n, more data will come, but it's important to think of GFR when you're dosing.
That, there was a session yesterday on hydroxychloroquine levels, and very well done, good overview, confirmed a lot of data from Michelle, therapeutic levels being 750 to 1150, I think was the number.
Yeah.
And but they talked about the population of people who had renal insufficiency also in there, and that's the great thing about monitoring. You're going to get the level, and you dose adjust according to that. So this kind of tells us what you're talking about a priori before you start knowing what their GFR is. You're going to dose adjust, but then ultimately, if you should be doing levels. We all should be doing levels, I believe. Then you'll really know where to be and how to keep the patient safe. Amongst the four of us, who's doing hydroxychloroquine levels in their patients?
Nobody
Yeah, me neither.
really.
Access, can't get them.
Access.
Well, you can get them now in the US with a commercial lab. So yeah, we're all in different countries. Glasgow, Leeds, Canada, and I'm in Dallas. So I can get it. I have the worst excuse, except I'm working in a charity clinic. I tried to get my university to do it before I left, and they had all kinds of. I think that they are going to get it, or they're just about to get it now. But I think that we're at a disadvantage by not doing it, and I think that you should ask around about where you can get it and ask about your commercial lab. I think LabCorp is capable of doing that right now. I don't know about Quest in the United States, but anyway. Any other comments on this? User, what do you
Yeah,
think?
yeah. So just to back up, yeah. So the abstract yesterday was a OP0199. Yeah, I think that the abstract highlighted the importance of monitoring, particularly people with CKD stage 3, at least. Yeah. So I think the 4 and 5 is okay, but I think for CKD stage 3 and above, they tend to you can get more increased risk of retinal and cardiotoxicity. So I think it's quite important to monitor them. Just quite out of interest, because we don't, or there's only a few sites in the UK that can do, hydroxychloroquine monitoring. And if we want to do it, we have to send to London. But there's some feedback also mentioning that, the turnover was quite long, take a while. So I'm just wondering, like in your areas, and Jack, how long turnover is before you get the script results?
Okay. Um, Again, I think we got to make a pitch to get this available to us. It really improves monitoring. I remember Madrid, EULAR, many years ago, and Michelle first presented this. I said, is this for anything more than, compliance? And she said, oh, yes, as only Michelle Petrie would. All right, my first is the ARIA study, which is OP0325 presented today. Nice follow-up to the ARIA presentation that was presented 2 years ago. In this study, it's an RA prevention trial, patients who are ACPA positive, also having evidence of subclinical synovitis by either MR ultrasound. 98 of them are enrolled and randomized to either receive standard dose of abatacept or placebo for 6 months, and then they go off of the ABA and they're followed for another 12 months with an 18-month endpoint. At 6 months, there was obviously significant protection in those on abatacept, only 8% developing RA versus 35% who were on placebo. Even in that time period, there was those who were taking abatacept were afforded about a 15-week RA disease-free sort of zone just in that first 6 months. When the patients were followed out to 18 months, there was still protection. 35% on ABA and 57% on placebo went on to develop RA. And in this study that they're doing, presenting here, they follow patients out. They're following them out for 9 years. They're reporting at this point a median of 5.9 years, where even at this point, there still is benefit with about 10 months of being RA free when you compare the two cohorts over time. What I liked about this study, a little bit like the treat earlier study um, that we just talked about, is it gives us some instruction as to who might be the best candidates to receive this treatment. And in their study, what the way they looked at it was what were the clinical parameters that they saw in patients who developed RA during the trial, the period of observation, and then after 18 months, developed RA after 18 months, because many did, and the ones that never developed RA. And what they showed that was significant was that markers of systemic inflammation, CRP being best, SED rate, were really good, along with pain VAS, tender joint counts, hack score, rheumatoid factor. Those are the main ones that basically said when things were looking really, and those are baseline numbers, predicted those who would progress and those who wouldn't. So the ones who had tender joint counts or tender joints or painful joints of 2 or less were less likely, in fact, to progress, whereas the ones that had 5 or 6. So the idea is the worse that you are on those systemic and pain and rheumatoid factor. Interesting thing to get into the trial, you had to have subclinical synovitis. But throughout the trial, they did serial MRIs on people, and the MRIs were not predictive as time went on. Either osteitis, synovitis, or tenosynovitis, which we know from the work of many, including the Leeds group, tenosynovitis is highly predictive of who's going to go on and develop further inflammatory arthritis, what looks like RA. So again, I think it's instructive. I think it's a good, well done study, and that's why it was an oral presentation. Any comments? Orly, what do you think of this data? You were in the same session as I.
Yeah, I think, I mean, the body of evidence is kind of accumulating that some interventions seem to work in some patient in some way, but I think what we need to be better at now that we have all this evidence is to maybe stratify people really well and try to understand. It might be, I was kind of saying earlier, that there might be some subgroups of patients that would benefit from one intervention and some group, like the methotrexate in the ACPA negative, and then maybe uh, those highly ACPA positive. These patients are a higher risk anyway to have severe RA if they develop RA. So that might be something else to take into account. And I think this is exactly what you just described was the results of of ARIA.
So there's a recent EULAR ACR risk stratification paper for CSA patients, clinically suspect arthralgia, telling you who's at risk to develop RA. This is what you're talking about, Orly, is who's at risk that they probably need treatment that you can predict who needs to get it. And we know it's ACPA, and we know it's subclinical synovitis, and that's why it's not just 30% who get RA, but when you start adding on these other things, it goes as high as 60, 70%. But some of these papers, like yours, with seronegative, and this ARIA one telling us that rheumatoid factor and hack scores are also helpful. I think it helps. A few more comments, and we need to move on.
Oh, I
No?
agree. I think it's more will come in this space, like you said earlier. It's exciting still.
Okay. Let's go on. Our next round is going to be a quick round. I'm going to ask short presentations, very short comments, even though what we're presenting gets us all excited and we want to talk too much, and I'm talking to myself here mainly. So again, who wants to go first? Orly, why don't you start?
Yeah, sure. So, okay, quick one in the gout space. I got excited because I've not seen many RCTs in the gout space in a long time. And so there was oral presentation 0302 phase 3 RCT. So it's a new class, but it's not the only drug of that class. There was other stuff presented before, in particular ACR, but it's called Ruzinurad, and it comes together with another one which has a pretty similar name. They are urate 1 inhibitors. So what they do basically when patient takes them is that the patient, it increases excretion of urate through the kidney. So immediately what you think about is side effects, potentially nephrolithiasis, and it's been reported. But in this trial, what they did is they had the allopurinol group, they had the rusinurad group, and basically the rusinurad was doing better in reducing the levels of urate under the target of 360 micromole per liter in their population. They had quite a few patients in there, and the safety profile was actually not bad. They had a few upper tract infections. They had a few, liver enzyme elevation, which is the case with allopurinol anyways. So the tolerance looked pretty good, the profile, in my opinion. So that was a Chinese trial. There was another presentation just before that, OP0300, with another of these drug looking into tophaceous gout and chronic gouty arthritis as well, and it seems to be working as well in combination with allopurinol in these severe patients. So I think this is a space to watch, and I thought that was quite exciting.
Yeah, URAT inhibitors, we've been waiting for them for years. They seem to have promise. I think it's not too far in the future that we'll be using those. Let's go on to using your next quick hit.
Yep. So my abstract title is poster tour. So POS 0325. So this work was done by my group, for which I'm the senior author. So essentially, there's so many presentation at this EULAR about CAR T therapies, and the main aim is to induce deeper depletion and also hopefully be immunosuppression free. But you can also get a super response with rituximab. So we look into our cohort. So we have 148 patients treated with rituximab, but we excluded a few. So we only included 114 because some of them we excluded because they were retreated on a clinical relapse. So you couldn't access, the duration of rituximab on it. So what we found of those 114 patients, there were 20% of patients who had really long response to one single cycle of rituximab, so lasted for more than 3 years. And of this, as 20%, so 7 patients, so equivalent to 8 patients, so equivalent to 7%, actually were immunosuppression free after 12 months, the first 12 months rituximab, and they seem to be doing really well. So we were really interested to characterize this patient who are we considered as super responder, and what we found that the factors predicting this super responder included those who had a severe prognostic marker, such as the non-European ancestry, your Black and Southeast Asian, and people with concomitant APS, and also if you use rituximab earlier, so shorter disease duration. So this really put all things together that if you calls for if you start using rituximab earlier in this poor prognostic patients, so they will have a better outcome and also long response as well. So that's the thing, and it is also serves as a pilot that I'm currently trying to prepare. So we're doing a multi-center trial in the UK to use rituximab as first-line biologic in early diagnosed moderate to severe lupus. So I think that's probably watch this space in the next few years. Yeah.
Janet, what do you think?
I think this is really cool. Interesting because I don't use it very much. We had access issues in lupus, but in RA, I've seen super long responders, but interestingly used, I've only seen them at about 2 or 3 years out of rituximab, a gram times two, if they're not in remission, another gram times two in 6 months. This is an RA. And then in Canada, we got access by treating them when they flared. And I've had people that maybe got 3 courses, and now I have 1 or 2 of them 6 years out, and I forget what they're on because they're not on anything. They're just on hydroxychloroquine, and the trainees say, how come they're only on that? And I go, well, I think they're still on rituximab. So we had some people in RCTs and RA reflex and dancer that were possibly permanently CD19 or 20 B cell depleted, but getting no infections. We haven't had to redose them in ages. And so I think we sometimes forget this can be a pretty cool drug for some patients.
Like you, Janet, I've used a ton of rituximab because I did all the trials and a big believer, but I'm not a big believer in lupus. Too many
No, I
rheumatologists,
don't.
in my opinion, are, and that reflects frustration. So I like that you're going to do a trial, but where is it going to go when it's not currently a therapy that's being marketed for that? And we have coming up very soon, approval of the other anti-CD20 obinutuzumab. But so why do the trial when there's going to be a better drug coming up?
Yeah, so I think what we're trying to say here is not all just about, so, for example, like in the CAR T. So there are other mediums of, if you got better depletion, you should get a better response. So I think that's the key, finding from our study. So the reason why we use rituximab is a pragmatic trial, and rituximab, for example, in the UK is so cheap. Now biosimilar, it's cost less than £400. Per course. So that is so cheap. Whereas obinutuzumab, we still have to wait a little bit longer. And if you do want to do another trials using obinutuzumab, then it will just incur the cost even more, for the funders. So I think that's the reason, because in UK and quite a few other areas that you can actually use rituximab. I believe I agree. I spoke to one of the colleagues just now from Canada. I think they said that rituximab is really expensive in Canada to use for that setting. Yeah. Mm.
Okay, let's move on, Janet.
Okay, two really quick ones because they're on my
Really
hydroxychloroquine
quick,
for
if
my
there's two.
lupus. Oh, don't worry, two sentences. So, RCT of herpes zoster vaccination in lupus, because they can get quite a high response to the vaccine. They already proved it was safe and effective. This just showed in the RCT poster 1005 that at 1 year there's still good humoral and cellular immunity, and they didn't have many patients flaring, etc. So pretty cool. Number two, real quick, poster 0983. How does hydroxychloroquine work? So I always taught the trainees and I learned it stabilizes lysosomal membranes, whatever that means, right? So this was kind of cool. Mild lupus patients only on hydroxychloroquine monotherapy. Some had been sicker in past, one had had lupus nephritis in past, followed about every 3 to 6 months. They had low SLEDAIs coming in. They did single cell seq, and they're giving the average of the small n of patients. But what they found was the cytokine signals can change even when, so some background noise, and not everyone has the same signals. But drum roll, interferon type 1 is reduced in hydroxychloroquine and some type 2 as well. So maybe that's why it's a really good background drug when that cytokine can be quite important in some of our patients.
Janet, was there any specific cell subtypes where the signature was reduced? Did you?
Right. So they looked, so to me, it's a small N. Single cell seq doesn't need a big N, but they looked in people that had skin, people that had prior lupus nephritis, no one had active at the time. And there could be differences, but there's also some background cells that are very different in some of the different organs. And I think
Right.
it's an orchestra, and interferon's just part of the orchestra.
Mm.
Yeah, so just to add about that vaccination earlier as well, I think the one of the analysis that they did was they look into the titer, of the humoral response and cellular response, but it seems like both of them were declining slowly over time. So I think it'll be interesting to see what happened after that 1 year, and then it just pose a question like, how frequent do you need to vaccinate, with this adjuvant Shingrix, for vaccine for herpes zoster prevention. So yeah, that's interesting, and we can compare that, with lupus and also like other rheumatic diseases. Yeah. Mhm.
And would MMF and things make a difference too?
Yeah.
Because that seems to attenuate a lot of vaccines like COVID.
Mhm.
Oh, yeah. All right, so our last one is going to be poster number 1051, presented by Marie-Therese Holzer in Germany. The title was an eye catcher as I walked by. It's myositis in the ICU. And it's their collective experience of 23 patients with idiopathic inflammatory myopathy of different types that were admitted to the ICU. This cohort, on average, was admitted for 32 days. The bad news is there were 5 deaths.
Mm.
What? There were 14 patients who needed mechanical ventilation. The deaths were either from bleeds or infection. So these people were generally admitted to the ICU for myositis, infection, surgery, other reasons, but the real reasons were mostly myopathy and lung reasons. And myopathy presented as not just weakness, but like dysphagia and myocarditis and whatnot. Complications of lung disease was the other thing. The types of patients were a third of them was the biggest subset of dermatomyositis. 17% had overlap, 17% were MCTDs, 10% were polymyositis, and I think it was 9% that had necrotizing myositis. Again, the other interesting factor here was at baseline, at entry, the majority of them were on myositis treatment. 87% were on steroids. These people tend to be on high steroids. They're a mess, and they get more steroid-related complications. They get more serious infectious events and hospitalizations and deaths, and we need to be cognizant of that. And that's why I like this particular abstract.
Right. MDA5, did they say how prevalent it was, Jack?
Not looked at in their population. They didn't get in. They didn't get into the serologic subsets. This was a cohort analysis from 2014 to 2022. So maybe before people were doing MDA5, NXP2, TIF1 gamma subsetting. I must say, until those three came along, I almost never got myositis-specific antibodies. What was it going to do for me? It really was. But actually now it's so easy to get these autoantibodies, and these do have significant prognostic capabilities that I do tend to order them now. Okay. All right, folks, I want to thank our panel for a great discussion and being here, doing the extra overtime after a really busy day at EULAR. For you out there, you can see or hear the final day recap, day 4, tomorrow, same time, same channel, and follow us on Room Now. We have a lot of good content coming to you from Barcelona and EULAR 2025. Thanks, folks.